Rheumatoid arthritis is one of the most important topics in medicine and, of course, on your exam. We have talked about the articular manifestations before as well as the atlantoaxial subluxation. Today we'll focus more about the extra-articular manifestations in rheumatoid arthritis, stuff such as those rheumatoid nodules, the carditis, the pulmonary fibrosis, the pleurisy and the pericarditis, the carpal tunnel syndrome, the scleritis and episcleritis, the anemia, etc., etc., etc. In previous videos, we have talked about the associations, the complications of rheumatoid, and the articular manifestations. Today, we'll focus on the extra-articular manifestations. So we divide them into general and organ-specific. Organ-specific, like what I just got some organs from my patient Rose, my imaginary patient. So we have heart problem, vascular problem, renal problem, lung problems, and the pleura. We have salivary gland problems, we have eye problems, we have nerve problems such as carpal tunnel syndrome. If your professor asks you what traps the median nerve, answer flexor retinaculum or transverse carpal ligament. You can have rheumatoid nodules and other nodules in other places, including the lungs. And of course, you have hematological abnormalities. Extra-articular manifestations, when, before, or after the arthritis. So, you can have extra-articular manifestations before the articular arthritis. Yep, prevalence, 40% of RA patients. So sad. Why? Because rheumatoid arthritis is a systemic inflammatory disease. Who is susceptible? Any patient with rheumatoid factor positive, anti-CCP positive, called seropositive, cigarette smoking, big time, early onset arthritis. Types, we have general extra-articular manifestations and organ-specific such as heart, lung, kidney, etc. Let's start with the general or the constitutional symptoms: fatigue, malaise or malaise, anorexia leading to weight loss, leading to, even cachexia, depression and weakness. Life is tough. Question: mention a famous rheumatological disease that causes depression. Answer: rheumatoid arthritis. Second, mention a famous endocrinal disease that causes depression. Answer: hypothyroidism. Now, the organ-specific extra-articular manifestations. First, cardio. Did you know rheumatoid arthritis can affect any layer or all layers, called pancarditis, but most commonly, because common things are common, pericardium, causing pericarditis with pericardial effusion in less than 10% of rheumatoid arthritis patients. What is the most common extra-articular manifestation in rheumatoid? Let me know down below in the comment section. Pericarditis, chest pain in the precordial region, which may radiate to the arm or the back. Oh yeah, because it's the precordium. Decrease by leaning forward, decrease by pressing on the chest, by increase by leaning backward, because when you lean backward, you stretch your pericardium, causing pain. There are two types of pericarditis that can happen in rheumatoid. We have the fibrinous pericarditis and the constrictive pericarditis. Let's start with fibrinous. If the pathology professors asks you about fibrinous, just say shaggy appearance. Full mark, baby, full mark. Okay. Is it exudate or transudate? Of course it's gonna be exudate. Okay, let's go to internal medicine. Friction rub. What the flip is friction rub? Okay, you know your grandpa, may he rest in peace, he had like an old pair of shoes that he got from England back in the day when the industry was great, during the Industrial Revolution 2 centuries ago. Get the pair of shoes of grandpa and get the sole of each one facing each other and then rub them together. This is the friction rub. Okay, don't use your stupid plastic sneakers. It's not gonna work. You need something iconic. In cases of pericarditis, the friction rub is triphasic, which means 3 sounds per cardiac cycle, like this. Which is different from the pleurisy, because pleurisy is biphasic. Because inhalation, exhalation, like this. But the cardiology, the pericarditis, is triphasic. Systole, early diastole, late diastole. So, lub, dub, lub, like this. Okay? So, lub, dub, lub dub, lub dub, lub sh dub, lub sh, like this. I'm crazy. Next type, we have the constrictive pericarditis. What's the most common cause? Where I grew up, Egypt, if I'm practicing medicine in Egypt and I have a patient with constrictive pericarditis because I heard lub knock instead of lub dub, I ask one question. Have you ever been diagnosed with tuberculosis? Yes, makes perfect sense because the most common cause of constrictive pericarditis in third world countries is tuberculosis. Then I came to the United States. If I hear lub knock on the chest of the patient with my great stethoscope, I ask one question. Have you ever had an open heart surgery before? Yes, makes perfect sense. I'm not shocked because scarring after an open heart surgery is the most common cause of constrictive pericarditis in the first world countries. That's why knowing your patient's backgrounds is huge. It's really important. Dystrophic calcification. We have two types of calcification. Dystrophic when calcium destroys a local tissue. Dystrophic calcium destroys. And then the metastatic calcification. Metastasis, it's not cancer, but it feels like cancer. Metastasis means you already have a systemic generalized problem that has increased calcium. For example, hyperparathyroidism. You have calcium all over the place, and then the calcium will damage tissue. So the problem is systemic, not local like dystrophic. Alright, and constrictive pericarditis has the famous lub knock. So S1, lub. S2, instead of dub, it's lub knock. Why? Because the pericardium is here. The outer layer has been calcified. Okay. And as you know, your heart is pumping blood. The ventricles contract. S1. The ventricles relax. And when they relax, S2, they hit the calcified pericardium producing a knock. It's a knock on bone. Lub knock, lub knock, lub knock. Constrictive pericarditis. Now we're done with pericarditis. Let's talk about the pericardial effusion. You have fluid surrounding your heart. It's an exudate leading to muffled heart sound. You put the stethoscope on the precordium, you hear the sounds very, very low volume, muffled. Why? Because there is water, and water will inhibit or interfere with sound transmission, as you know from physics. Pressure is equal in 4 chambers. Why? Because there is water all over the place, and the pressures inside the chambers become equal with the pressure on the surrounding water because the water controls everything, acts as a sponge or something. Then you have Kussmaul's sign. What the flip is that? Ask the patient to inhale. Look at the neck vein, you find jugular venous distension. This is called Kussmaul's sign. One of the causes of Kussmaul's sign is pericardial effusion. Then we have pulsus paradoxus. Ask the patient to inhale. The systolic blood pressure decreased by more than 10 millimeters mercury. What else in rheumatoid? You can have myocarditis with effusion and thickness. You can have rheumatoid nodules on the valve, which is very important, and try to remember this when we talk about lupus later. Secondary cardiomyopathy, granulomatous mitral valve disease leading to mitral regurgitation. Okay, you need a pearl. Rheumatoid arthritis never causes a valvular stenosis. It's not gonna happen. If rheumatoid is gonna damage your valve, it's gonna be regurgitation and not stenosis. Cardiac amyloidosis, because rheumatoid is a chronic inflammation. Permanent AV block, which is horrible. And this is different from carotid sinus hypersensitivity, because in carotid sinus syndrome, it's not permanent. Question: why does rheumatoid has permanent AV block? Due to that granulomatous involvement of the myocardium. And as you know, your cardiac cells in the myocardium are specialized cells that can transport impulses. Rheumatoid can lead to CHF, aortitis, and coronary artery disease, which is the most common cause of death in rheumatoid patients. Next, let's talk about vascular. Rheumatoid vasculitis. Okay. Also known as necrotizing angioitis. Who is susceptible? The patient with rheumatoid factor positive, anti-CCP positive, cigarette smoking big time, and early onset arthritis. they are susceptible to rheumatoid vasculitis, also known as rheumatoid arthritis, not arthritis. Big difference. Location around the ankle and in the heart. Aortitis and coronary problems. Pathophysiology, it's an immune complex deposition, type 3 hypersensitivity reaction leading to small vessel vasculitis. Watch my video on pathophysiology of rheumatoid. Accompanied by necrosis, nail fold infarct, splinter hemorrhage. Do you remember? Skin ulcer, infarction, gangrene, livedo reticularis, petechiae, and purpura. Horrible stuff. As a general rule, vasculitis is divided into infectious, syphilitic, rickettsial, mycobacterial, and non-infectious. It could be large, medium, or small. Medium and small and small. Rheumatoid could either affect all of them or it could affect medium and small only. If you have to choose the small vessel vasculitis. But rheumatoid can affect all three. Contrast that with lupus. When we talk about lupus later, lupus is only small to medium, something like that. Let's talk about the lungs in rheumatoid arthritis. Lung problems in rheumatoid are commoner in males than females. Pleuritis with pleural effusion. Remember cardiology? We had pancarditis and pericarditis with pericardial effusion. Here we have pleurisy with pleural effusion. Pleurisy, you have pleuritic chest pain. Pleuritic means what? It increases when you inhale. It's related to breathing. And this is different from the heart attack. Heart attack has nothing to do with breathing. The patient can be breathing in, breathing out, holding his breath. He still is going to have the pain. But the pain of pleurisy only appears with respiration. Ask the patient to hold breath, like exhale and hold. Do you have any pain? No, disappeared. Breathe again. Oh, it hurts. This is pleuritic chest pain. Increases with deep breathing because you are extending your pleura. Oh, it hurts. And decreased with holding breath. Hold your breath. Any pain? Nope. Is it an exudate or a transudate? It's an exudate. And the effusion in rheumatoid arthritis have some specifics. Low glucose, low pH, increased neutrophils, increased monocytes. Why is that? We'll talk about this in pulmonology lectures later because it's a big subject. Friction rub of pleuritis and pleural effusion. Describe the friction rub of pleuritis or pleurisy. It's biphasic. This is different from the cardiology one because the pericarditis was triphasic. Big difference. Lungs, biphasic, because lungs you inhale and exhale. There are only two. Cardiology we have three. We have systolic, early diastolic, late diastolic. And we have pseudochylous effusion. And this is different from chylous effusion. Why? Pseudochylous is not even chyle, and you have increased cholesterol. Chylous, on the other hand, they have increased triglycerides. Interstitial lung disease, big time, with or without nodules. So the nodules in rheumatoid, you can find them on the skin. You can find them on the heart valve. You can find them in the lung. The interstitial lung fibrosis in rheumatoid is basal. Okay, not apical, it's basal. Contrast that with the seronegative spondyloarthropathies. These are apical and we'll talk about them later. Pulmonary function test, restrictive pattern. What do you mean? Decreased total lung capacity. We call it restrictive lung disease. The lung space is restricted. It's narrower. You have decreased the space of exchange, so the total lung capacity is decreased. And decreased DLCO, which is diffusing capacity of carbon monoxide. What are the symptoms of a patient with interstitial lung disease? Dry cough, shortness of breath, which is progressive. If you do HRCT, which is a high-resolution CT scan, you'll find infiltrative opacities with honeycomb changes. Whenever I go to Starbucks and the barista asks me, "Sir, would you like some honey in your coffee?" I remember the interstitial lung fibrosis and respond back, "No, thank you." What a miserable life. Then we have something famous called traction bronchiectasis, and we'll talk about this later when we talk about pulmonology. If you want to know about it, okay, here are your bronchioles, okay, in the lung, if you take a cross-section. They are surrounded by lung tissue, interstitial lung disease. In interstitial lung disease, you have fibrosis. You have fibrosed these, so these fibers become short, they are fibrosed. When they fibrose, they cause what? Traction. They start pulling on those bronchioles, leading them to dilate. The word ectasia means dilate. Bronchiectasis, the bronchioles are dilating. Medicine makes sense with medicosis perfectionalis. Rheumatoid arthritis and salivary gland. You have chronic sialadenitis of major salivary gland. Major. This is different from Sjogren syndrome because Sjogren has chronic sialadenitis of minor salivary glands. Sjogren should go to jail. Why? Because he affects minors. Bad person. Bad Sjogren. Usually asymptomatic. The eye, we have red eye. If you ask an ophthalmologist what are the causes of red eye, he will smile and then he will tell you like a very big list that include more than 45 conditions and he will make your life miserable. One of the causes of red eyes is rheumatoid arthritis. Keratoconjunctivitis sicca is the most common manifestation of rheumatoid eye symptoms. And this is also known as secondary Sjogren because primary Sjogren is autoimmune. Secondary is secondary to something else, in this case rheumatoid. Dry eyes, dry mouth. And this is different from primary Sjogren because primary Sjogren has dry eye, dry mouth, and arthritis. Dry eyes, the patient complains of, "Doctor, I feel some sand in my eyes." Dry mouth, "I can't chew a cracker," which in England and in Egypt it's called biscuit, but in the United States it's called cracker because biscuit in the United States means something else called biscuit, some kind of bread, which is absolutely delicious. Because biscuit in America is as American as the apple pie. And by the way, you put gravy on the biscuit, you put ice on the cake, you put a cherry on a cheesecake. This is federal law. What else? You have episcleritis and scleritis. Scleritis, painful, and it can rupture causing scleral perforation. Let's talk about nerves. Medicosis. I'm a young student. I don't want to memorize. Okay. You want to memorize only two things. Number one, carpal tunnel syndrome affecting the median nerve. Number two, mononeuritis multiplex. Okay? Alright, go to hell. Carpal tunnel syndrome, median nerve entrapment. If your anatomy professor wanna sound cool, okay. The median nerve is entrapped under what structure? Answer, flexor retinaculum. If you don't find it in the choices, choose transverse carpal ligament. We have tingling, numbness, paresthesia, and positive Phalen's and Tinel's test for median nerve entrapment. Motor symptoms, decreased wrist flexion on the radial side. Let's draw a wrist like here. So here is your nice right wrist. Right. Okay, nice and cozy like this. So you're trying to flex your wrist, but the median side, because we have the median nerve here and the ulnar is here. So here is ulnar, don't care about this. The median nerve is affected. Okay, you cannot flex the wrist on the radial side, on this side. This will lead to ulnar deviation because you can't flex this. When you try to flex it, the ulnar nerve is still functional. It will pull your wrist this way, called ulnar deviation. But this is not the ulnar deviation of rheumatoid arthritis because the ulnar deviation of rheumatoid arthritis is in the MCP and not the wrist. Big difference. And we have decreased flexion of the 3.5 fingers here. Those lateral 3.5 fingers, you cannot flex them because the median nerve is affected. Sensory problems, decreased sensation of the lateral 3.5 fingers. And we have thenar atrophy because the muscles here have atrophied and because they are not getting any nerve supply, they will atrophy. The thenar eminence will be flat. What else other than carpal tunnel syndrome? Peripheral neuropathy, such as mononeuritis multiplex. This is like a stupid name. Whoever named this disease should be hanged by the testicles, metaphorically speaking. Because let me ask you a question. Mononeuritis multiplex. Is this a mononeuropathy or polyneuropathy? Okay, medicosis, it's called mononeuritis, so it should be mononeuropathy. But it's also called multiplex. Oh, this is confusing. So what is it? The answer is it's a polyneuropathy. Stupid name. Okay, this polyneuropathy will lead to what? It will lead to wrist drop due to damage of which nerve? The radial nerve. And can also lead to foot drop due to damage to which nerve? The fibular nerve. And if you are an old dinosaur like me, it was called the peroneal nerve in the past. Why? Why do we get peripheral neuropathy in case of rheumatoid? Because in rheumatoid we have vasculitis. You'll get vasculitis of the vasa nervosa that feed the nerve. Also, you can have radiculopathy and myelopathy, the compressive myelopathy of the C1, C2 subluxation. We've talked about this before. Why radiculopathy? Because pannus grows like cancer. I'm not saying it's cancer, but it behaves as if it's cancer. Pannus is horrible. It keeps growing and growing and growing, destroying all of the surrounding tissue and eating it alive. Skin manifestations in rheumatoid, we have the rheumatoid nodules. These subcutaneous nodules of rheumatoid are firm or soft, rubbery, and non-tender. This is different from osteo because osteo had osteophytes, bone, so it's not soft, it's hard. This is different from gout because in gout you have tophi, you have crystals. It's gonna be hard, but rheumatoid nodules are soft. They adhere to whatever on the extensor surface of the elbow, sacrum, etc., and they can happen in the lung and on the heart valve and on the serous membrane. A student is asking me, hey, medicosis, why the extensor surface? Why not the flexor surface? Because the extensor surface is subject to trauma and pressure. Next, we have Baker cyst, also known as popliteal cyst, swollen bursa on the back of the knee. If you remember my fictionary rheumatoid patient called Rose, she had a Baker cyst behind her knee. This is swollen bursa behind the knee, non-pulsatile, it's not an aneurysm. Can it rupture? Yes, and when it ruptures, it causes swollen calf. It can occlude the vein from the outside. So here's the nice vein, all right, and here's the Baker cyst, occluding the vein from the outside, and this can mimic DVT if you are a stupid doctor. So pay attention. Next, we have pyoderma gangrenosum, single or multiple, large, non-peeling, painful. Why? Because rheumatoid is inflammatory. Redness, hotness, swelling, pain, loss of function. Ulcer with prominent red, redness, hotness, swelling, pain, so red border. Start as small and then small papule, and then the papules get infected, forming pus. We call it pustule, and then it ulcerates, forming and it enlarges. Why does it enlarge? Because redness, hotness, swelling. It enlarges, baby. Okay, anemia in rheumatoid, we'll talk about it in a separate video, but don't forget neutropenia, Felty syndrome, and TLGL, lymphoma, diffuse large B-cell, which is a non-Hodgkin's lymphoma, and thrombocytosis. All of these can happen in rheumatoid. Let me summarize everything for you in 1 minute. Extra-articular manifestations of rheumatoid can be general, such as fatigue, weakness, malaria, okay, and then can be organ-specific. How about the heart? You have pericarditis with effusion. You can have nodules on the valves. The most common cause of death is coronary artery disease, and there is an increased risk of atherosclerosis. How about the vessels? Vasculitis, such as aortitis. How about the kidney? Glomerulonephritis and amyloidosis. Primary or secondary? Secondary because rheumatoid is a chronic inflammation. Next, let's talk about the lungs. You have pleurisy, which is pleuritis. You have pleural effusion. You have basal interstitial pulmonary fibrosis. You might have nodules in the lung. We'll call this Kaplan syndrome. And we'll have salivary gland, dry mouth, dry eye, episcleritis and scleritis. Nerves, we have carpal tunnel syndrome and mononeuritis multiplex, subcutaneous nodules, and then we have the blood problems, anemia. If the question asks you what's the most morphology of anemia in rheumatoid, answer normocytic, normochromic. You can have neutropenia, lymphoma, and thrombocytosis. What kind of lymphoma? Non-Hodgkin's. Specifically, diffuse large B-cell lymphoma. Thank you so much for watching. Please subscribe and join the tribe. Hit the bell. Follow me on Facebook. I have more than 100 cases there. Get all of my notes and all of my cases on patreon.com/medicosis. Thank you so much for watching. This is Medicosis Perfect Skills, where medicine makes perfect sense. Until next time, please be safe, stay happy, and study hard.